Ulcerations of the oral mucosa can be classified as aphthous and non-aphthous ulcerations. In this presentation, we will address ulcerations that are different from aphthae. Knowing that these ulcerations may correspond to numerous diagnoses whose principal etiologies are trauma, inflammatory responses, tumour reactions, or infection. Non-aphthous ulcerations may affect the gingiva. The main type is necrotizing ulcerative gingivitis. All cases of necrotizing ulcerative gingivitis should suggest a malignant hemopathy and necrotizing ulcerative gingivitis, NUG, caused by plaque. In all cases, the practitioner will need to request a complete blood count as a matter of routine. The following differential diagnoses of necrotizing ulcerative gingivitis should be considered. Herpetic gingivostomatitis, which is very often accompanied by lesions involving the vermilion zone of the lip. Eruption gingivitis, caused by an irregularity of dental development. In this case, the partially erupted tooth will be visible, often accompanied by a periodontal infectious process characterized by the presence of erythema and pus. Finally, in exceptional cases, necrotizing gingivitis of bacterial origin can be observed, mainly in a context of immunosuppression. Non-aphthous ulcerations may have a traumatic cause. In effect, the mouth may harbour many prosthetic devices which can traumatize the tissues and lead to ulcerations. Acute ulcerations are characterized by a fibrinous base with a more or less erythematous perimeter, whilst chronic ulcerations are characterized by a fibrinous base and the presence of an associated keratosis. Lichen planus is an autoinflammatory pathology that causes inflammation. In lichen planus, the inflammation is associated with keratosis and often has the appearance of a network. Lichen planus is a progressive inflammatory pathology which can develop into tissue atrophy and, to a variable degree, keratinization. For example, leukoplakia, proliferative verrucous leukoplakia, or verrucous carcinoma. Finally, in less than 1% of cases, lichen planus can degenerate into squamous cell carcinoma. Lichen planus is managed principally by local treatment. Dependent on treatment effectiveness and on adverse effects, the use of local clobetasol as first-line treatment can be recommended. Alongside lichen planus, there are lichenoid reactions. Graft versus host disease is a lichenoid reaction which can manifest as ulcerations that are often more extensive than classic lichen planus. Post-bullous ulcerations are a form of non-aphthous ulceration that should be mentioned. These are principally caused by autoimmune diseases, for example, bullous pemphigoid, where ulcerations will be sited away from the gingiva, and cicatricial or mucous membrane pemphigoid, where ulcerations are localized more specifically to the gingiva. Finally, necrotizing ciliometaplasia should be mentioned. This is a deep inflammatory response associated with necrosis of the minor salivary glands, expressed histologically as epithelial metaplasia, which sometimes causes this pathology to be mistaken for squamous cell carcinoma. Finally, syphilis must be thought of when considering non-aphthous ulcerations of infectious origin. In particular, secondary syphilis, which produces lingual ulcerations, typically described as a moan meadow, with a characteristic element, the bayet collarette, seen here surrounding palatine ulcerations. Tuberculosis should be mentioned as another ulceration of infectious origin. Often, the ulcerations are localized on the tongue as a result of contamination by sputum. Cytomegalovirus, CMV, ulcerations are rare ulcerations of the oral mucosa which have a relatively atypical appearance and which are observed in immunosuppressed patients. Alongside post-bullous ulcerations, post-vesicular ulcerations should be mentioned. These are principally caused by viral infections, the herpes type 1 virus, the varicella zoster virus, and the Coxsackie virus. In the majority of cases, these ulcerations are polycyclic. In the case of Coxsackie infections, they are located posteriorly. In herpes zoster, they are unilateral. And finally, in herpes, they preferentially affect keratinized mucosa, even if there are exceptions, as with the lingual ulcerations shown in this presentation. Fissural cheilitis is a specific form of ulceration. Cheilitis is sited specifically on the lips, mainly on the labial commissures. The case presented involves cheilitis caused by candidiasis in a context of diabetes associated with xerostomia. Classic angular cheilitis is often affected with impetigo. There is a bacterial superinfection which necessitates the use of local antiseptics, potentially antibiotics such as fusidin, and finally the fungal component can be treated with ketoconazole. Erythema multiforme will also produce ulcers in the oral cavity, which are atypical, pseudomembranous. The lesion that is most typical of erythema multiforme is, of course, the cutaneous target lesion with the characteristic bullseye appearance. In the case of mucous membrane erythema multiforme, the lesions are located solely in the mouth and other orifices. The diagnosis is often difficult if no cutaneous lesions are present. Most often, it is a question of diagnosis by exclusion. Toxic epidermal necrolysis in its mucosal form of Stevens-Johnson syndrome or in its cutaneous form of Lyell's syndrome is rare and is secondary to drug use. The mucosal form of Stevens-Johnson syndrome mainly affects the lips. The medical history taking will allow the diagnosis to be made. Finally, cancer ulcerations should be discussed. Squamous cell carcinoma of the oral cavity can manifest as ulcerations which are often associated with peripheral keratosis. In the case of ulceration linked to squamous cell carcinoma, there will be an ulceration with vegetating raised edges, and an induration will be detected on palpation. Sometimes squamous cell carcinoma of the oral mucosa produces extremely small ulcerated lesions. Here, on the lateral border of the tongue of a young patient, is the perpetuation of the lesion which led to the taking of a biopsy, which in this case enabled confirmation of the diagnosis of microinvasive squamous cell carcinoma.